Our next presenter is Professor Bikha Devrajani. He is Dean Postgraduates and Director International Liaisonning, University of Modern Sciences, Tando Muhammad Khan. Please welcome Professor Bikha Devrajani. He will be talking about the future of diabetes mellitus.
I will try to compensate the time. I am learning medicine and diabetes since 1980. Up to now, nothing to disclose. This is the current status of diabetes. You see the 589 million people are living with the diabetes. In 2050, the 853 million people will be diabetic. So we have to prevent, we have to treat the complication of diabetes as well. We have to think on this line. This is the global picture, globally the burden of the diabetes. In Asia, Southeast Asia, the rise of diabetes is 73%. So we are in this region, we must be think about. Diabetes causes these complications. And when we were the youngster, when we were student, there was the triplet of the diabetes. Hyperglycemia is because of insulin secretion defect and hepatic output more and less use of glucose. But world has changed, research has changed now. Now this is the ominous octet. So there are the 8 pathophysiological defects in diabetes: decreased incretin effect, decreased insulin secretion, and alpha cell secrete more glucagon, and liver hepatic output, glucose output is more. Some neurotransmitters in brain, they causes the hyperglycemia, decreased glucose uptake by muscles, and increased reabsorption from the kidney, and increased lipolysis. So these are 8 factors, they causes the hyperglycemia. And now previously we were talking about diabetes is the mother of the diseases. Now obesity is the mother of disease. Now this is also when we are treating the diabetic patient, we have to we want to prevent the diabetes, then we should look about the obesity. In the obesity, now the figure is 1 into 8 people they are obese, and 2.5 billion people they are overweight, and especially we are worried that 160 million people, children are having the obesity. So, and obesity is more in female. That is 21%, in male is 18%. Now, this is obesity is a global crisis, and in 1990 it was, it now figure is almost, you can see 1 out of 8, so figure is doubled. So what about the future? And this is the regional variation, and in Southeast Asia, of course, America 67% overweight prevalence, while in our Southeast Asia and Africa is 31%. And now obesity, 90% of all obese people having the diabetes, along with other all comorbidity, cardiovascular, hypertension, sleep apnea, stroke, certain cancers, osteoarthritis. Right now, 3.7 million people are dying because of obesity, because of a non-communicable disease due to high BMI. So fatty liver disease is also associated with this. And Professor Wasim Jafri has talked very well, so I will not, I will save my time. So metabolic syndrome, obesity, type 2 diabetes, hyperlipidemia, triglyceridemia, insulin resistance, hypertension, all these, and also additional complications are there. Now, talking about the specialty, you have learned a lot from the Wasim Jafri sahab. I am skipping these slides, and these are the medication available for the obesity, that is the resmetirom and 2 other drugs. They are in phase 3. They are phase 3 trials, so they will be shown in the market. Now, this is the future direction for, now what medication we have available. When we are making any recipe, then we should think about the things available with us. And then we will mix in proper quantity, and then we'll make a dinner or lunch. So what medication we have available within our hand? Medical nutrition therapy, this is consists of diet and exercise, and so full plan exercise. oral agents, the insulin secretor, biguanoids, thioglutamide, alpha glutamate inhibitors, DPP4 inhibitors, and insulin therapies, all different types of insulin therapy. And then sulfonylurea, first generation, second generation, third generation, and sulfonylurea, they increase the insulin from pancreas, while they have got a side effect that just weight gain and hypoglycemia, and there is obesity in diabetes as well. So we want to prevent the diabetes, then we have to prevent the obesity as well. So we must take care of about this drug when we are prescribing. Repaglinide, litaglinide, they also, and also weight gain and hypoglycemia. And there are some contraindication of these medications, just like kidney disease, liver disease, hypersensitivity, pregnancy. So we must keep these as a physician while prescribing the medicine. Insulin sensitizer, metformin. This was the #1 drug and magic drug, but because of two side effects, GI disturbance and metabolic taste, and it's still used in different guidelines as a first-line therapy, but it causes the vitamin B12 deficiency anemia, vitamin B12 deficiency in the diabetic patient, and diabetic patient, there will be the lack of B12, there's hyperhomocystinemia that will worsen the peripheral neuropathy. So we must keep in our mind about this medication as well. Then thioglutamate, this causes the edema and weight gain. This is a good drug for the fatty liver, but and this causes the edema and weight gain. So there are a lot of the contraindication, heart failure, ischemic heart disease, pregnancy. And alpha glutamate inhibitors, they cause the GI, the GI disturbance. So in our country, many people, because of our hygienic food and hygienic water, so they have got a GIT problem. So patient usually they cannot tolerate this medication well. DPP4 inhibitors is the increases the life of the incretins. And so by adding all these drugs, by a single medical nutrition therapy, we can reduce by hemoglobin A1C by 1%. By oral agents, single monotherapy, 2%. By all the combination of the oral drugs and insulin by oral drugs, then 3% A1C reduction. And by adding the insulin, we can reduce the blood sugar as we want. But that insulin causes the obesity. Even in type 1 diabetic children, when they are taking the insulin dose higher and higher, and they are also taking the sweet and sweet things, then they become obese and they become having the secondary failure. So this is another challenge for us to manage the patients of these. So incretins, we know there are two incretins available, glucagon-like peptides, GLP, and GIPs. And the GLPs and the GIPs, one is GIPs is secreted from the proximal intestine, that is the K cell, and GLP is secreted by L cell, distal small intestine. And this is the list of available GLP-1 analogs. And up to GLP-1 receptor agonist, peptide, and now we have the dual and triple therapy is also available in the market. So these are the effect, GLP-1 receptor agonist causes the effectively reduce the A1C, preserve the beta cell function, inhibit the glucagon secretion, promote the weight loss, correct the 6 pathophysiological defects. So this is correcting 6 pathophysiological defects. And it do not cause hypoglycemia, have an excellent safety profile, and reduce cardiovascular and renal events. So this is the beauty of this drug. So this was a trial, and primary outcome was MASH, and secondary outcome. And GLP-1 receptor in cardiovascular protection, it causes the anti-atherogenic, anti-inflammatory, antioxidative, anti-thrombotic. It's a direct effect on myocardial muscles. It causes the weight loss, decrease post-renal lipemia, reduce blood pressure. So this is really good for the cardiovascular disease. Now these two GLP and GIPs, when we compare, then triptazide with the semaglutide, triptazide causes the more weight reduction, but semaglutide is still the good drug for other reasons. But if patient having the obese, moderate obesity, extreme obesity, then we should prepare the triptazide, okay? Prefer the triptazide. These are the SGLT2 inhibitors available in the market. And SGLT2 inhibitor mechanism of action, it causes the So these are the mechanism. It reduces the insulin resistance, decreases the glucose, decreases the weight loss and causes the weight loss, reduce visceral fat, and also decrease blood pressure, decrease plasma, arterial stiffness, and sympathetic nervous system overactivity will be reduced, inflammation and oxidative stress to the heart will reduce. So this is the mechanism of action of the SGLT2 inhibitors. So ominous octet for diabetic nephropathy. These are number one is the hypoxemia, then different hypertension, tubular growth and factor hypothesis, genetics of course, obesity, and DLN tubuloglobullar feedback, hyperglycemia, and podocyte dropout, albuminuria, and obesity. So SGLT2 inhibitor acts on decrease the blood pressure, acts on the tubular growth and focal hypothesis, and it also decreases the, it also affects on the dearranged tubuloglobullar glomerular feedback. It decreases the hyperglycemia. It also helps in podocytes drop out, albuminuria, and so this is the, and also affect on the obesity. So this covers these 6 defects in diabetic nephropathy. So in the summary, the benefit of the SGLT2 inhibitor is the A1C, reduction of A1C, beta cell function preservation, decrease insulin resistance, increase weight loss, decrease blood pressure, decrease cardiovascular disease, decrease heart failure, renal function, and also effects on the muscle D, as Professor Jafri Saab has told. Retinopathy, still research is going on but not proved yet. So these are the guidelines. ATA guideline says that with the atherosclerotic atherosclerotic heart disease, coronary artery disease, and with the indicator of high coronary cardiovascular diseases. So number one is GLP or SGLT2. And if the heart failure is there, is predominant, then SGLT2 will be first, SGLT2 should be given. So this is about the ADA guideline. The European Endocrine Society say the GLP-1 receptor agonist is also class 1, SGLT2 inhibitor is also class 1, and independent of hemoglobin A1C. And metformin and pioglitazone is, this is class 2A and class 2B, and then add on the medications. So evidence-based, whatever we learned, I was thinking, this is my algorithm. I was thinking, my brain thinking that in SGLT should be, SGLT2 inhibitor should be first, then GLP receptor agonist, then pioglitazone, and then metformin. But in the country, just like our poor countries, low economical countries, SGLT2 inhibitor, metformin, then of course DPP4 inhibitors, and pioglitazone and fatty liver, and then the combination of the SGLT2, DPP4 inhibitor and metformin, then finally sulfonylurea, then insulin we can use. But this is not ideal. So, so future treatment, personalized medicine, dual triple incretin agonist like GLP-1 and GIP, oral version of these drugs, AI-driven therapies, genetic coding for beta cell degeneration, stem cell therapies, and nanomedicine for precise delivery, duodenal mucosal resurfacing to potentially cure the condition by targeting it. My idea that why not we should start the drug, which is a major drug, which is preventing and curing the disease, that is the GLP-1 receptor agonist, and local pharmaceutical company has made very cheapest, so we can use this in our patient earlier, and many researchers are going on. I will skip these slides. These are the different research, and with this, so this is take a home message is the individualized therapy based on pathophysiology, comorbidity, and patient characteristics, early intervention to preserve the beta cell and delay the progression of the disease. Combination therapy, it is multiple pathophysiological defect. Cardiorenal focus is important, and so GLP-1 receptor agonist and SGLT2 inhibitor, then add-on, and these will be the future therapy. Thank you very much. Thank you, sir. Thank you for patiently listening.
Thank you very much, sir, for completing well before time.